Hi, Dr. Lala. Hi.
Hello, Dr.
Live now.
The team members can all switch on their videos also, please.
We are
Trying to fix the background. Sorry, I'll be on very soon.
Manjula, we are live?
yes, Doctor, we are live.
Okay.
We can
Thank
start.
you. Yes, I'll go ahead. A very good afternoon, everyone. I am super excited to be one of the moderators at Yosi iROCK International Season 2. And after a successful Season 1, we really didn't know we would have such an amazing comeback. We have 6 total teams today. Unfortunately, we just have one team who denoted some event or incident, so they won't be playing here. But the rest of the 5, I wish them all good luck and one banger song for you to welcome here.
Ritu, the sound is not coming. I think you need to share sound before you, when you screen share.
I just did, but I'll...
Yeah. It's not coming, Ritu. Can you again share your screen and just tick on the share sound button? Yes. It's not coming, Ritu. Can you share it again? Have you ticked on the share sound option? When you screen share, there's a share sound icon which comes. You have to tick on that. Only then your sound will be played. We can't hear you also, Ritu, now. Sahil, you have the backup PPT?
I have the backup PPT, ma'am.
Can you start sharing?
Yeah. Just one.
Ritu is fixing the thing. Yeah, Ritu is sharing it. Ritu is not coming. Can you just stop sharing? Let Sahil share the screen, please. Ritu, can you speak something? I think there's an issue with your audio. Just speak something. No, yeah, we can't hear you. I think there's some issue with your own. Yeah. I think you can rejoin Ritu once. Ritu, we can't hear you. Maybe disconnect your headphones.
Shall I start with this, ma'am, at this point of time?
Yes.
Okay,
Yes,
ma'am.
Sahil, start, please.
Yes, ma'am.
Make sure you click the share sound option.
Yes, ma'am. Okay. The slides are visible.
Yes. Put it on
Okay.
screen, full screen mode. Yeah.
So welcome everyone, the whole team. Welcome judges. This afternoon, Sunday, we'll be having the first session of the International Yosi iROCK season 2. So as Dr. Ritu mentioned that after the overwhelming response of the season 1, we have gone international this time, and all thanks to Dr. Nipo ma'am and under guidance and the GC of the Yosi that we have brought it to an international platform this time. And let's start with the initial introductory video, which will give a small glimpse of what we are going to have today in the Yosi itself. So, as I would like to thank the team Yosi of 2024-26 with past president as Dr. Sonal Kalia ma'am and the present president Dr. Divakant Mishra sir for giving this the opportunity to the whole team Yosi. And as for the residents who are new to this Yosi platform or Yosi concept, I would like to bring to your attention that Yosi is not just one thing, but it has multiple wings, and you can spread your wings and you can explore multiple things, not just nationally, not just in India, but across the international platform. And in India itself, we have multiple aspects to Yosi. So go through the website and try to be an active part of the Yosi. This was the last year's Yosi iROCK session 2024, where we have 34 residents team pan India, 8 online prelim sessions, 3 semi-final sessions, and 1 physical finale, and then finally 1 grand finale, which happened at the annual YosiCon. And it was like it was a marathon, not just for the residents, but for the moderator like us to conduct such a session. And we are really happy that 7 teams were nominated iROCK Star, and 3 teams were nominated as iROCK Superstars. These were the sessions and the details, and each session was concentrated on one or the other subspecialty of ophthalmology. Then these were the semi-final sessions. These both were online, and then we had physical finale and grand finale at the YosiCon, and these were the winners of the last year. Here, that is first prize, second prize, third prize. As you can see, it was also a combination of west, south, and north part of India winning across the Yosi session. And this is the new logo which has been designed by Dr. Nilesh, and the earlier logo also was designed by Dr. Nilesh, and it shows how the residents are fighting across, not just on this platform, but also I think on their daily basis in this competitive eye care field. This is a team Yosi iROCK of the season 2 under the team lead as Dr. Nupul Goyam, and we are here to go through this session, and I'm really thankful to Dr. Nupur ma'am for all this guidance which she has taken across. So we'll give a small brief of what will be happening this time. A small change that this time we will not be having a semi-final session, rather we'll be having these prelim sessions. 4 prelim sessions will be there, and 6 teams are there in each prelim sessions, and out of these each prelim 2 top teams will be selected for the physical grand finale at the finale and the grand finale at the 3rd annual YosiCon, which will be happening in during 10 to 12th of July 2026. And out of these prelim sessions, 8 finalist teams will be selected, and from this finalist session, they will be nominated as iROCK Stars. And finally, out of these will be selecting top 3 teams who will be awarded as iROCK Superstars, and they will be given the prizes of travel grants, etc. at the YosiCon. So finale and the grand finale will be happening physically at the YosiCon on July 2026, 10 to 12th, New Delhi. So block your dates, block your tickets, and be there either as a participant or either as a delegate. But try to enjoy this session of Yosi Con annual annual conference. So 4 rounds. First round in this whole quiz sessions, each prelim sessions, everything the pattern will be the same. First will be the seminar presentation. Second will be a creative round where a reel will be played. Third round will be a quiz, and fourth round will be unscrambled words. We will be having audience prizes in between. I would like to now start with the introduction of judges, and I really thank them from the bottom of my heart, and the team Yosi thank them that they are participating and they are taking time in their most precious time on that too on a Sunday afternoon, and they have joined us to evaluate the residents. And initially, the first judge, Dr. Lala ma'am, and she has an experience of approximately over 11 years of experience in vitro retina, cataract surgeon, medical retina. She has been a part of YO in Azerbaijan as a national representative. She is a secretary of Azerbaijan Young Ophthalmologist Committee. She is part of American Academy of Ophthalmology, where also she is a YO national representative. She has again in Turkish Republic Ophthalmology Society. She's been the YO president. She is a part of Global YO Alliance, and she is again a representative from Young Ophthalmologist side in the Azerbaijan. Thank you, ma'am, for giving your valuable time. I hope you enjoyed this session. And the second judge is Dr. Nimesh Jain, sir, a very close senior and a friend of mine. And he did his post-graduation from BJ Medical College and DNP from Prabha Eye Clinic. He did his fellowship from Narayan Nethralaya and has been active academician plus clinician and in the vitreoretinal aspect with multiple representations in state and national international conference, and more importantly, he is on central advisory board in Bayer and Zydus, and has more than 10 years of practice in the private sector. Dr. Hardik Jain, again a very close friend and a senior of mine. He did it via fellowship from Retina Foundation, and had worked as vitreoretinal consultant at GBH America Hospital in Udaipur and Chautram Nethralaya Indore, and has multiple publication. Presently, he is working as a VR surgeon at Jain Eye Hospital, which is own setup at Baswada, Rajasthan. I welcome Dr. Vibhuti Kashyap sir, Deputy Director and Head at Kashyap Memorial Eye Hospital in Ranchi, and he has done his post-graduation and super specialization from RP Center, AIMS, New Delhi. A very good thing is that he is the pioneer of multiple new treatment modalities in retina in his state, like surgeries for stage 5 ROP, subretinal injections, and many more new inventions and new innovations. And he is the first to win in 2 Rhett Buckler trophies that are considered as Oscar of Surgical Retina in a single year at ASCRS Annual Scientific Committee. We are honored to have you, sir, and this will be a great session, and I hope it is not just be an academic, but a fun come academic part for all of us.
So Dr. Sahil, what
No,
we got to
yeah.
know about Dr. Vibhuti is that he's a newly elected executive of the AIS committee as the ARC representative of the elite zone.
Oh.
Congratulations, Dr. Vibhuti, for
Amen.
that. Yes.
Sure. Now I would like to invite Dr. Roma ma'am to please continue with the introduction of the moderators and the participants. I'll keep sharing the presentation. I'll mute myself.
Thank you, Dr. Sahil. So let's go ahead with our moderators for today's session. First is Dr. Sahil Bhandari, who is presently working as a vitreoretinal consultant at Guru Hasti Netra Chikitsalaya, Piper City, Jodhpur. He also runs a 100-bedded charitable eye hospital in the rural block of Piper City. He has done his MBBS from Stanley Medical College, Chennai. He has done his diploma from RIO, Chennai, followed by DNB and fellowship in vitreoretinal services from Arvind Eye Hospital, Pondicherry. He has also acquired FICO, MRCA, FAICO cataract, and he is presently the executive member of Jodhpur Ophthalmic Society. He is a very skilled eye surgeon, a very good friend of mine, and his expertise in clinical eye service and community ophthalmology. He's interested in academics, and he's also an ex-senior resident at AIBS Jodhpur. Welcome, Dr. Sahil. Next is Dr. Ritu Singh. She is currently working as an assistant professor, AIMS CAPFIMS, New Delhi. She is an executive member of Yosi. She has done her MBBS from GSBM Medical College, Kanpur, and MS Ophthalmology from KGMC, Lucknow. She has more than 30 presentations credited to her name, and she has also delivered faculty talk at national and international forum. She has 6 index publication and 1 book chapter credited to her name. She is a recipient of national and international travel grant. She has also got a Best Paper Award in UK SOS and DOS. And she is also the recipient of multiple awards like AIOS IGO Silver Award and UC International Rising Star Award. Welcome, Dr. Ritu. Then myself, Dr. Roma Johari. I am currently working as a glaucoma consultant at Sri Shankar Nethralaya and Pixel Eye Hospital, Hyderabad. I have done my MBBS from KMC Mangalore, from my DOMS from Bangalore Medical College, MS from CMC Vellore, followed by my glaucoma fellowship from HB Desai, Pune. So welcome all. And now we'll go ahead with our participant for today. We have a very energetic and enthusiastic team. So first is our international team, Triple IQ. They are from Khyber Teaching Hospital, Peshawar, Pakistan. The team captain is Dr. Shafaq Tanveer. She is a resident, and followed by the other team members, Dr. Farhan Mazhar and Dr. Mariam Khilji. Welcome team Triple IQ to this session. Next is Team Vision Ledger. The captain of the team is Dr. Ayushi Modi. She is the PG third year resident of Government Bundelkhand Medical College, Sagar, Madhya Pradesh. And she is also joined by other two, Dr. Itisha Ghia and Dr. Ayushi Mahajan. Welcome Team Vision Ledger. Third team is Team IQ Squared. The team captain is Dr. Sakshi Raj. She is a JR at Civil Hospital, Palwal, Haryana. And she is joined by the other two team members, Dr. Namrata Chaudhary. She is the junior resident at Raj Eye Institute and PG Hospital, Gorakhpur, UP. And Dr. Harshita Dal, junior resident at Raj Eye Institute and Gorakhpur. Welcome all. Next is Team iSpice. They are from KMCT Medical College, Kozhikode, Kerala. The team captain is Dr. Shritu Suresh. She's a junior resident, and Dr. Kritika and Dr. Asla are joining her. Welcome, Team iSpice. Unfortunately, Team I Got This couldn't join us. So next is Team Iconic Tanner with us. The team captain is Dr. Tanvi Sharma. She's a DNB resident at Arvind Eye Hospital, Chennai, and she is joined by Dr. Ameya and Dr. Neil Jain. Welcome, Iconic Tanner. Now I'll hand over to Dr. Sahil for the inviting GC.
I would like to invite, I think Dr. Nilesh sir has joined. I think, can we get an update?
Yes, sir.
From
I
the
am
group.
here.
Yes,
Okay,
yeah,
okay.
Dr. Neil.
Sir, please welcome for the first
Yeah.
session, and I hope it's going on fine at this point of time.
Yes,
And
sir.
please give your guidance and support to the team, and please give a few words about how was the previous session and what are we expecting from this current session.
Thank you. Thank you so much, sir. So, first of all, I would like to thank Devakant sir for having this idea of creating a international competition for residents all across, residents and fellows, that was iROCK and fellows face off. But as he always says, the ideas come dime a dozen unless the implementation is there. So the implementation by the team led by Nupur ma'am has been fantabulous for last year. It was a mammoth task to conduct so many webinars. Every weekend they were having a session, and then to do a semi-final and then a final at Yosi Con. That was a great endeavor from the entire team led by Nikhil. And we are really grateful that this is a property that has been created, which is being implemented by other societies as well in India and across. So to find the best president that is possible. So for this, adding the international team has been a game changer, and thanks to President for bringing the international teams on board for that. And with that, I think I'd like to congratulate everyone and give all the best to the entire team, because this is a long task ahead, next 3 to 4 months. to do all the webinars and get the best residents to YosiCon to fight the final battle. And thank you all the participants as well. Without you guys participating, this would not have been possible. Thank you so much. Back to you, Saizer and Ritu.
Thank you, Dr. Nilesh. And I would like to say a few words that Dr. Nilesh, I think, is the most super active person in the OC as a whole team. And I think his energy is mutually conducted across the whole GC itself. And he has designed this Yosi iROCK second logo also. And he's an amazing person. And really, it is very difficult to explain the way he is handling not just one wing, I think almost all the wings of the Yosi, and he's available to us, I think, any point of the time. And so I thank Dr. Nilesh from bottom of my heart, and thank you for all the
Thank you.
motivational words.
Thank you, sir.
Motivational.
Thank you so much.
Yeah. So now I would like to call upon Dr. Ritu, our moderator, to take up the further seminar sessions, and which will be the round first.
I hope I'm audible now. Yes.
Yes,
Okay.
yes.
Thank you. So let's kickstart. And are you sharing the screen? Yeah. Thank you
Yeah,
so
can
much.
I say a few
So
words too before you proceed?
yes, definitely, ma'am.
Yeah.
Dr. Nupur.
Yeah.
She is the brainchild behind the Yosi iROCK, and I'm so sorry. Just because I had this thing in my mind that my audio broke down, I would definitely want her to speak more than 5 minutes, more than 10 minutes on all the things
Yeah.
that she had curated. Nothing of this would have been possible without her. So, Dr. Nupur, please.
Yeah, so thank you, Dr. Ritu. So this is definitely not my brainchild. This is the brainchild of
Ma'am, your
Dr.
audio
Devakant.
is a little far off.
We can't hear you, Dr. Nupur. Sorry.
Yeah, is it fine now?
Yes, ma'am.
Super.
Is it good? Yes. So, so I was saying that this is definitely not my brainchild. It's a brainchild of Dr. Devakant, our president, and I think it's a team effort. What you're seeing today, we have a fabulous team. As you saw in the initial thing, even if one person is having a technical glitch, the other person had the backup presentation. So I think this is the iROCK team is an exemplary, the way is an example how a teamwork should be, and it's for you to see. We had a fantabulous season one, and with this season two going international with the efforts of Dr. Prasanna, I think sky is the limit. And welcome everybody. Thank you everyone, to all the participants, to all the judges. We have international judges also on board. This time we are joined by Dr. Lala, and of course all our esteemed judges, Dr. Vibhuti, Dr. Nimesh, Dr. Hardik. Thank you so much for joining us, and to all the participants, wishing you all the very best, and looking forward to a great session. And we look forward to having all of you at YosiCon. Irrespective of whether you make it as the Yosi iROCK star or not, do come for YosiCon. Trust me, it has something exciting for everybody, right from socio-cultural to academics to wet labs. So just make the most of it. And with this, without further much ado, I will hand it over back to Dr. Ritu to go on with the session.
Thank you,
Yes,
ma'am.
over to you, Dr.
A mere 2-word speech, I think, from your end is so infectious. I am pumped up with excitement now. So, teams, let me brief you. We have 4 rounds today. First round would be iLeague, that is your seminar presentation on a pre-decided topic. Moving forward to round 2, that's Pupils Got Talent, where you present any creative round, which will be either reel or dance or music. Round 3 is Knowledge Nexus, which is a rapid fire quiz where you present your buzzer and fastest finger first talent as well. And last round is Wordsmith War, something that you did in kindergarten, unscramble your letters. So next slide, please. Moving to the first round, iLeague, and I welcome the first team. Make sure that the presentation time is within 5 minutes, or you'll have negative marks. If you exceed 5 minutes, 15 seconds, that's your buffer time, 15 seconds only. Your question and answer would continue after your seminar presentation for 2 minutes. And the first team here would be Triple IQ. They have been allotted their topic beforehand. Triple IQ, you can share your screen.
I'll stop sharing. Triple IQ, you
Yes,
can
yes.
start sharing. Let us know when you start. So okay, we can start the timer. Are ready? You need to unmute also. Yeah. Full screen.
Hello, everyone.
Full screen.
Sir, just wait a second. I'll just begin my slideshow so that we can start.
Yeah, you let me know, then only I'll start the time. Ready?
Yes, sir.
Okay, start please.
Hello and good afternoon, everyone. I am Shafaq Tanvi, team captain of the team Triple IQ from Khyber Teaching Hospital, Peshawar, Pakistan. And today I'm going to present my presentation on diabetic macular edema, which is essentially fluid accumulation in the extracellular spaces within the retina, mainly within the inner nuclear layer and outer plexiform layers of the retina. But sometimes it also can accumulate in the subretinal space as well. Now, the important thing to note is that diabetic macular edema is a type of maculopathy which is very distinct from diabetic retinopathy. So it can essentially develop in any stage of diabetic retinopathy from mild NPDR to high-risk PDR, but the systemic risk factor of both the DR and DME are essentially the same, which is duration of diabetes, control of diabetes, other systemic abnormalities such as hypertension, impaired renal function, and dyslipidemias. The pathophysiological mechanism of formation of DME mainly consists of two pathways. One of them is the disruption of blood-retinal barrier by extensive hyperglycemia, which leads to loss of pericytes and accumulation of the fluid. And the other one, which is not very common, is the inflammatory pathway, because it is stated that certain inflammatory factors and cytokines such as vascular endothelial growth factor, matrix metalloproteinases, and interleukin-6 are involved in the formation of DME. That's why steroids do play a certain role in the resolution of diabetic macular edema. Now, as far as the diagnosis of the diabetic macular edema is concerned, optical coherence tomography is the mainstay of diagnosing the disease, staging the disease. Moreover, it also helps in monitoring the prognosis of the disease and response to the treatment. The main prognostic factors on OCT include disorganization of the retinal inner layer, disruption of ellipsoid zone, and vitromacular interface abnormalities. It is worthy to note that drill is the most important prognostic factor for treatment response to DME, more so than visual acuity and central subfoveal thickness. OCT also classifies diabetic macular edema into two types based on the central 1 mm subfoveal thickness zone involved. It categorizes it into center-involved diabetic macular edema when the fluid is within that 1 mm area, and non-center involved diabetic macular edema when the fluid is outside that area and it truly have an effect on the treatment option that we select for the patient. Coming towards the treatment of diabetic macular edema, anti-VEGF is the gold standard for therapy, which basically became the gold standard after Protocol I of DRCR network, in which the ranibizumab has essentially similar response to laser photocoagulation, which was previously the gold standard treatment. Protocol T of the DRCR network states that if the vision is worse than 20/50, aflibercept is a superior choice, whereas vision better than this, all three anti-VEGF acts exactly the same. Alternative treatment options include steroid, although certain implants of steroids have been approved by FDA for treatment of DME, but they are usually used in persistent DME or in pseudophakic patients because they have high rates of cataract formation and IOP spikes after the use of steroids. Laser, whereas previously it was a mainstay of treatment, now it is only limited to the treatment in non-centered involved diabetic macular edema. We use two types of laser, focal and macular laser, depending upon the type of leakage that is present. In focal laser, we mainly take use from fundus fluorescein angiography, which helps us highlight the macroaneurysm, and we hit that. Whereas in the macular grid laser, diffuse macular thickness is employed. Pars plana vitrectomy is a surgical option that has not widespread proven to be having any effect except for DRCR network Protocol D, in which TRD was associated with improvement. So when we talk about DME management, we should keep this flow chart in mind. If the patient is asymptomatic, we do not need to do anything. But if the vision is worse than 20/32, we can initiate anti-VEGF therapy. If there is persistent DME, we can switch to corticosteroid. And if there is dragging on the macula, we can simply opt for vitrectomy. These are essential takeaways from my presentation. OCT is an indisputable primary tool for detecting, classifying, and quantifying macular thickening. Anatomy dictates action, and anti-VEGF is the first line treatment. And with this, I thank you all.
Yes, you may please stop sharing. That was a wonderful presentation. Thank you so much. And we have the mentor, Dr. Nazli Gul, Assistant Professor at Khyber Teaching Hospital, Peshawar. And I would like to take her inputs first before I go ahead with a small rebuttal. The judges would grill you later. So, is your mentor here with you? Dr. Nazli? I guess she had joined and left. Don't fret. One of your teammates can call her up, and we'll take in first the judges' comments and Q&A session. You have 2 minutes, and I'll first go with Dr. Nimesh Jain, sir.
Good afternoon, all. Yeah, so wonderful presentation, team from Pakistan. But I have few questions for you. First and foremost is you have not mentioned what are the grading of DME. Do you know about the grades of DME?
Sir, I know about the classification of DME, but not the grades.
Okay, fine. So there is a grading for DME where you have graded DMEs in the form of spongy edema, cystoid macular edema, vitromacular interface. So it is a way of treating the disease. The grade of DME also helps us to decide on the guidelines how to go ahead with the DME treatment. Okay. Second question is, do you have any clear-cut criteria to treat diabetic macular edema only with steroids, and where you don't prefer anti-VEGF when you give it the steroids as a first choice?
Sir, when there are any systemic problems in a patient like cardiovascular disease or anything like that, in which the patient is not fit for the use of antivascular endothelial growth factor, then we can go for steroid. But according to the protocol B and protocol E of DRCI network, the use of steroid as a first-line agent is not proven.
Okay. Well, I think that this is a relative contraindication, systemic risk factors, but patients with classical having more of hard exudates in the clinical picture, steroids shows as a very good response as compared to that of an anti-VEGF situations. So steroid is an indicator that it's a chronic CME, and chronic CME generally it's more of an inflammatory one, and you see a steroid as a first step or the first line treatment in that situation specifically. Okay, any role of PRP in treating macular edemas?
Sir, it can only if the severe NPDR or PDR is present, we can take help from PRP because it will help reduce the formation of VEGF, and hence the inflammatory pathway will shut down as a result. But for mild NPDR, it has not shown any effect. In fact, it worsens macular edema.
And what is your say on macular ischemia related edemas? If it is an ischemic macula and an edema is happening in that situation, do you think that the anti-VEGF will worsen up the situation, or will it improve the situation?
Sir, ischemic retina will produce VEGF, so I think it will improve the situation.
But I think VEGF induces more amount of ischemia. If in case you give an anti-VEGF and it is not required, or it will induce more ischemia, because VEGF is too required for the vascularization to happen, for the vessels to work. But if in case you give an anti-VEGF in a situation where VEGF is already low, will a macular status related edema worsen up with a VEGF, anti-VEGF, or it will improve with an anti-VEGF?
Sir, in that case, it will worsen.
It will not change. Only the clinical picture will change, but the situation, you will see the edema is going up, but the vision will absolutely showing no changes to you, because anti-VEGF do plays a role in an inflammatory pathway also. So it will reduce the inflammation and it will still work, but patient will feel that there is no improvement in vision. Okay, I'll ask other judges to please carry on with the judging part. Thank you very much and a wonderful
Thank you,
presentation.
sir. Thank you, sir. Ma'am, our mentor has joined.
Ritu, you are not audible.
Hi everyone.
Yes. Welcome, Dr. Nazli Gul.
Thank you. Hi, I'm Dr. Nazli from Khyber Teaching Hospital and the mentor of all the three candidates of today's contest.
Thank you so much.
Nice being there. You're welcome.
They really need your support and +5 bonus points. Thank you for joining in, ma'am.
Thank you.
We'll resume with the judges' comments and Q&A session. Dr. Bibhuti, you can unmute yourself. Yeah, thank you so much.
Yeah, hi, Shafak, fantastic presentation considering the time constraints. Couple of inputs. Firstly, in the indications of surgery, do you have any other surgical indications for diabetic macular edema apart from what you mentioned? You mentioned the posterior highlight traction or ERM formation. Any other indication for surgery in a diabetic macular edema apart from these two?
Sir, vitreomacular traction, epiretinal membrane formation, and traction retinal detachment.
I mean, it's a corollary of all of those, but sometimes in a recalcitrant macular edema, which is non-responsive to an anti-VEGF, you may also go for a PPV with ILM peeling. It improves the penetrability of the anti-VEGFs. So that is one point I wanted to mention. Second, and the second question, the last question that I'm going to ask you is, if you have a patient with DME and cataract, what is the sequence of the procedures if you have to perform a cataract surgery and you have to treat the macular edema with anti-VEGF? What is the sequence, the interval, and your rationale for that?
Sir, according to the protocol P of DRCR network, if DME and cataract coexist, then we first treat diabetic macular edema followed by cataract extraction. And if the patient, according to the protocol Q of DRCR network, if the patient has had episode of diabetic macular edema in the past, whether center or non-center involved, it will develop a certain amount of diabetic macular edema after cataract surgery.
Yeah, so when you do a injection first and then cataract surgery, what is the duration of interval that you keep?
Sir, 1 week.
Good, thank you.
Thank you, sir.
Thank you, sir. I'll go next with Dr. Lala. Ma'am, please, your comments and questions.
Sorry, I have another problems. You asked for me, yeah?
Sorry, ma'am?
You asked from me, yeah? I have another
Yes.
problem.
Yes.
Yeah.
Your turn, ma'am.
I think the Team Triple IQ presentation was so clear and so well organized. Great presentation. Thanks for that. And my colleagues also add the additional comments and inputs as well. I have only one question that when you according to the OCT, the thickness of the macular, which number of the thickness will forward you to start the VEGF treatment, or you're also only doing that according to the vision acuity?
Ma'am, for thickness, we also have certain cutoffs. For men, the central thickness of greater than 320 micron is an indication for anti-VEGF, whereas for the females, the thickness of 305 micron is the initiating point for the anti-VEGF. But we also look at the vision of the patient. If the vision is improved, or if the vision is good, it is more than 6/9, then we do not usually go for anti-VEGF treatment and we observe the patient.
Thank you for answering my question. Thank you. Great presentation. I have no anymore.
Thank you, ma'am.
You're going great, Dr. Shafak. And lastly, we have Dr. Hardik. Please go ahead. Dr. Hardik, sir, you can unmute yourself. Yeah.
Am I audible now?
Yes, sir.
It was a very decent presentation by the team Triple Q. And I hope I don't have any more questions, because I think most of the things have been covered by Dr. Nimeshwar and the ma'am as well. So I would just request we shall go ahead to the other presentation.
Okay, sir. Definitely. Thank you so much. And this was Team Triple IQ. We'll move ahead, and the next team is Vision Ledger. You can share your screen. And all the best.
Ma'am, can I start?
Yes, we'll just, yeah, your
So myself,
timer has
Dr.
begun.
Tisha Gia. My topic for presentation is endophthalmitis. So basically, it is an intraocular inflammation which predominantly affects the inner courts of the eye, and it can be infectious and sometimes non-infectious in nature. It can be classified on the basis of infectivity as infectious and non-infectious, based on mode of entry as endogenous and exogenous, and exogenous further classified into post-traumatic, post-operative, and bleb-related endophthalmitis, and post-operative is further classified into acute and chronic endophthalmitis. So endogenous endophthalmitis is a result of hematogenous spread of microorganism to the eye. The most common predisposing factors are diabetes and immunocompromised patients, and these are the most common sites for intraocular infections. The pathogenesis of endogenous endophthalmitis comprises of there is a primary source of infection which metastatically spreads to the ocular posterior segment vasculature, and it acts as a the septic embolus acts as a nidus and crosses the blood retinal barrier and spread from posterior to anterior chamber. Coming to exogenous endophthalmitis, it can be post-traumatic, post-operative, and bleb-related endophthalmitis. The pathogenesis of exogenous endophthalmitis, basically there's microbial inoculation, cascade of inflammatory products, inflammatory cell recruitment, cytokine storm, tissue damage, and vision loss due to inflammatory response. Coming to post-traumatic endophthalmitis, it can be due to open globe injuries and intraocular foreign bodies. The risk factors are rural setting trauma, vegetative matter injury, delayed repair after 24 hours, ocular tissue prolapse, placement of primary IOL, extent of injury, and lens disruption. The post-operative endophthalmitis can be acute onset, in which onset of symptom is less than 6 weeks of surgery, and delayed onset, in which onset of symptoms are within more than 6 weeks after surgery. It can be due to post-cataract surgery, post-vitrectomy, post-penetrating corneal surgery, especially penetrating keratoplasty and keratoprosthesis, and intravitreal injections. So in post-cataract surgery, it is typically associated with defects in the surgical wound or violation of the posterior lens capsule, which provides a route for the entry of infectious agent in the vitreous cavity. These are the most commonly causative organisms according to the EVA study in post-cataract endophthalmitis. In bleb-related endophthalmitis, it can be early leakage due to wound dehiscence or late onset due to adjunctive antimetabolite use. Patient of endophthalmitis usually presents with ocular pain, diminished vision, increased redness, discharge, and photophobia. The signs can be lid edema, conjunctival hyperemia, corneal edema, keratic precipitates, cells and flare in the anterior chamber, hypopyon, vitreous haze, and retinal periphlebitis and papillitis. Coming to fungal endophthalmitis, it can be due to candida, which has specific features like string of pearl appearance in vitreous opacities and bilateral white, well-defined circumscribed chorioretinal lesion of less than 1 mm diameter. And aspergillus endophthalmitis has a confluent yellow infiltrate in the choroid and subretinal space. Diagnostic evaluation is done by culture from intraocular samples, can be done with PCR and blood culture. Then the culture has to be repeated if there is no response to antibiotics, presence of contamination in the media, or presence of any fungal organism. Negative culture may arise due to presence of fastidious organism, insufficient sampling, and sterile endophthalmitis. USG-B scan is done to look for the vitreous exudates and posterior vitreous detachment or retinal detachment. The treatment goals for endophthalmitis are rapid microbial eradication, control of inflammation, preserve ocular structure, and restore the visual function. So the prophylaxis for post-operative endophthalmitis is use of topical 5% povidone iodine and topical fluoroquinolone prior to the surgery. whenever there is a case in which we are clinically suspecting endophthalmitis, first is tap and inject, that is aqueous and vitreous tap, then immediate intravitreal antibiotics, adjunctive therapy, monitor and reassess at 48 to 72 hours. Immediate intravitreal antibiotics include vancomycin for gram-positive, ceftazidime for gram-negative, and amikacin for gram-negative. Adjunctive antibiotics are adjunctive therapy is topical antibiotics and intravitreal steroid. And steroids have to be avoided in fungal infections. Then we have to monitor the response. If there are signs of improvement, then continue same treatment. If there is no improvement, then repeat the vitreous tap and repeat intravitreal antibiotics. If there are signs of worsening, then urgent vitrectomy and change of antibiotics has to be done. According to the EVS study, if visual acuity is light perception or less, then immediate vitrectomy with intravitreal antibiotics is preferred. Coming to special cases like post-traumatic or endogenous endophthalmitis, in these cases, we have to add systemic antibiotics also. In delayed onset post-operative endophthalmitis due to Cutibacterium acnes, the treatment involves intravitreal vancomycin plus IOL and capsular bag removal. And in suspected fungal cases, intravitreal amphotericin B and voriconazole are given and steroids are avoided. Thank you.
My heart was racing while you were finishing it off. You just completed in the nick of time. It was a great presentation by Team Vision Ledgers. Yeah. And we have their mentor, Dr. Praveen Khare, with us. So if you would unmute yourself. Did he join, Dr. Itisha? Yes.
Hello.
Good afternoon, sir. Thank you for joining.
Sorry, I'm not in Sagar, so there's a little bit of chaos. But as a mentor, I feel really great that our resident got such an opportunity to participate at such a big level, because our institute is situated in a place which is not a very advanced city. But thank you all this organization that they are getting exposure to such a great platform, and this is genuinely helping them to improve in a much better way in academic. Their presentations are much better, and the kind of resources they are looking for their academic purposes is really improving. So thank you, team YOS, for this opportunity, and all the best for all these future presentations.
Thank you so much, sir. No matter how little or farther your city might be, the participants are they're doing a great job, sir. So indeed a great team. Let's take up judges' comments and questions. I'll ask Dr. Hardik Jain, sir, first. Your questions won't be taken up by any other judge this time.
Another beautiful presentation, guys. Just wanted to know, have you ever mixed vancomycin with ceftazidime? And if so, what happens?
So basically, vancomycin is not toxic to the retina, but ceftazidime can be retinotoxic in certain concentrations.
Mm-hmm. So, while giving and this ending any kind of intravitreal antibiotics, what is the sequence of giving it? Well, what do you inject first?
In the sequence of giving antibiotics, we usually inject the vancomycin first, and then followed by the antibiotic for gram-negative. And they don't have to be injected with the same syringe. They have to be injected separately. They don't have to be mixed.
What usually I do is most of us are doing is inject vanco, and then in between you can, if not in fungal suspected, then inject dexa, and then septa you can inject, because whenever you mix vanco and septa, the precipitates comes up.
Yeah.
So you cannot give them all together, or you cannot mix them in a single syringe as well.
Yes.
Okay. So very nice.
Thank you, sir.
Thank you, sir. Next judge would be Dr. Lala, please.
Thanks for your presentation. It was a little bit faster, but I understand you. It's a complicated thing, the endophthalmitis, the huge information always to give. You fixed that in 5 minutes. Congratulations. About the questions that are you using the Vanco software together if it's needed, or always trying to choose one of them, and the duration, are you doing that every day or doing with another way? One day you're doing, the other day you just follow up and then using that.
First, we'll inject and we'll analyze for 48 to 72 hours if the signs are improving or not, if the vitritis is subsiding or not. If there's no response even after 48 to 72 hours, then we'll inject again.
And are you using it both together if it's needed, or no?
Not
Because
both
there's a
together.
challenge sometimes using that two together.
Yeah,
If it's
Vanco and ceftazidime should not be used together as it reduces the efficacy of both the drugs.
yeah. Okay. And about the vitrectomy, I would like to ask that you finished your treatment and you have you have success, for instance, but you have blurry vitreous and you have some signs that it could be come back or any suspicious. Would you prefer to do the vitrectomy, or would you prefer to follow up?
Then we would prefer to do pars plana vitrectomy and then intravitreal
When you
continue
prefer
with intravitreal
vitrectomy,
antibiotics.
I'd like to ask that. When you prefer the vitrectomy to do? You started your antibiotics therapy and you continue and you have the success. You have vision acuity is getting improvement. When you will choose to do the vitrectomy, or will you continue till the end to clearance of the vitreous, or you choose the vitrectomy? If you choose the vitrectomy, so why?
If vitritis is still persistent, then we'll go for pars plana vitrectomy.
Okay. Thank you.
Thank you, ma'am. Dr. Bibhuti, sir, you may go next, please, with your question. So you would have to unmute yourself once. Yeah.
Audible now?
Perfect. Perfect.
Yeah, I'll be quick and short. Just one quick clinical scenario. Say on post-operative day one of an uneventful cataract surgery, a patient presents to you with cells of say 2+, and a very mild anterior vitreous reaction, not much of vitritis, and a very mild corneal haze, and you are confused between whether it's a TAS or an endophthalmitis. What's your approach on the first day on POD1?
Basically, TAS presents within 24 hours of cataract surgery. So first we'll treat it with steroids as TAS rapidly improves with steroid treatment, and endophthalmitis has poor response to steroids. And endophthalmitis has better response to antibiotics.
Yeah, but if you start steroids, the end-off may worsen if it is an endophthalmitis. So what is like your first treatment, and like when will you review the patient next?
Within 24 hours, we'll review the patient.
All right, that's it. Thank you.
Thank you, sir. Dr. Nimesh Jain, sir, over to you.
Yeah, a wonderful presentation. I'll just like to extend the question of Dr. Vibhuti. How do you differentiate a task from end-off?
Sir, basically, TAS presents within 24 hours of cataract surgery, and acute endophthalmitis or fulminant endophthalmitis presents within 3 to 4 days of cataract surgery. In TAS, there is anterior chamber reaction. In endophthalmitis, there is more prominent vitritis associated with it. Endophthalmitis, the patient presents with pain and severe diminution of vision, while in TAS, there is mild diminution of vision. TAS responds very well to steroids, whereas endophthalmitis responds very well to antibiotics. And in coming to corneal edema, in TAS there is limbus to limbus, like diffuse corneal edema, and in endophthalmitis there is mild to moderate corneal edema.
So the next question is, what is the role of oral steroids in endophthalmitis? Do you treat any cases with oral steroids?
So if it is sterile endophthalmitis, then we can go for oral steroids, but it has not there are no studies which suggest that oral steroids is any which way beneficial for endophthalmitis.
But I
And
think
steroids should never be started before antibiotics.
But I think you have been mentioning that intravitreal you give dexamethasone along with it, and oral steroids, if in case it's not playing any role, then steroids are playing a role.
So they can reduce the inflammatory damage, but they cannot reduce the infective load in the vitreous.
So that's what, if in case you have injected 2 doses and 48 hours or 72 hours apart, and you still see some amount of vitritis or vitreous membranes residual remaining, and you don't want to go ahead with the 3rd injection, can you still prefer oral steroids?
So we can go for oral steroids as an adjunctive therapy along with antibiotics, but not alone oral steroids can be given.
But now your answer has changed from completely, you're saying no role, now you've came to a role of steroids. You have turned that upside down.
In fungal, steroids are completely contraindicated.
Okay, it is not, leave that side if it is not fungal. Understood. Fungal will not give intravitreal also.
Yes, sir.
Okay, but what about the gram negative, gram positive, or atypical, whatever it is, leaving the fungal aside, role of oral steroids? Will you start it on day 1 or not?
On day 1, we won't start.
Day 1, you will not start.
Yes.
Okay, why?
So because it will not control the infective load, rather it will.
And then how will you differentiate TAS?
So TAS, in TAS there won't be marked vitritis. Vitreous involvement won't be there in TAS. Only anti-vitreous will be involved.
Okay. Fine. So we'll not go for the vitrectomy side. Vitrectomy will be a different agenda. We'll just end up over here. Thank you.
Thank you, sir.
Thank you so much, sir. It was great team vision ledgers, and you also get +5 because your mentor was here to support you.
Okay.
And the next team we have is 3rd team, and it's IQ squad. You can share your screen once, and team vision ledgers can mute themselves. Team IQ squad.
Hello.
Yes, you are audible.
Yes, ma'am. Ma'am, can you see my screen?
Yes, it's visible.
Okay.
And your time has begun. Yes.
Okay. So my topic for today is post-operative CME. Post-operative CME, CME is defined as thickening of retina at macula due to accumulation of intraretinal fluid following breakdown of any of the blood-retinal barriers. The fluid mostly collects in the outer plexiform layer of macula in form of honeycomb-like cystic spaces. Post-op CME is a sight-threatening complication that could affect visual recovery following a successful ocular surgery. Its incidence is reported in 60% of intracapsular surgeries, 15 to 30% of extracapsular, and 4 to 11% of phaco surgeries. CSME occurs in about 1 to 2% of patients undergoing cataract surgeries. Other surgeries can be following vitrectomy, rhegmatogenous RD, and the ERM. The incidence has been found to be 5, 10 to 25%, 13 to 47% respectively. Its pathophysiology is basically it is disruption of blood retinal barrier, leakage from perifoveal capillaries leading to accumulation of fluid in intracellular spaces, mainly in inner nuclear layer and outer plexiform layer, which then leads to photoreceptor architecture distortion leading to visual loss. It is often associated with intraocular inflammation mediated through release of prostaglandins and leukotrienes. Risk factors can be many: preoperative, intra and post-op. Few of pre-op risk factors can be uveitis, epiretinal membrane, vitreomacular traction, diabetes mellitus, diabetic retinopathy, and etc. Intra and post-op risk factors can be PCR, vitreous loss, iris manipulation, prolonged surgical time, retained lens fragments, and so on. Clinical features, symptoms can be decreased vision, metamorphosia, micropsia, central scotoma, decreased color vision, and contrast sensitivity. Signs can be loss of foveal reflex with cystic spaces, which can be seen in OCT, OCT is one of the most common investigation of choice. It shows cyst-like areas of low reflectivity, retinal thickening, loss of foveal depression. Occasionally, subretinal fluid accumulation can be seen as a non-reflective area beneath the neurosensory retina. Fluorescence angiography is also one more common investigation. It shows small focal fluorescent leaks and late pooling of the dye in late venous phase in extracellular cystoid spaces. It shows a flower petal petaloid pattern due to radial arrangement of Henle's layer. Treatment, it usually resolves spontaneously in most of the cases, even without treatment. However, it is impossible to predict which cases may become chronic. Hence, early treatment is beneficial. Medical treatment mostly involves topical steroids and topical NSAIDs. A prospective randomized clinical trial of chronic CME found that combination therapy with ketorolac 0.5% and prednisolone acetate 1% 4 times a day was more effective than either drug alone in improving visual acuity. Subcutaneous steroid injection or intravitreal injection of steroid alone or via a sustained drug delivery system may be effective. In refractive cases, systemic carbonic anhydrase inhibitors may be beneficial. Intravitreal VEGF have also been successful in chronic CME cases that do not respond to conventional treatment. When medical treatment fails, we resort to the surgical treatment. Any retained lens fragment should be removed if it is there. NDRG, laser vitreolysis or vitrectomy can be used to remove vitreous adhering to the cataract incision and relieve iris deformity. If the IOL is malpositioned and contributing to chronic uveitis, repositioning or exchange may be helpful. However, there is a study which shows that there was bilateral choroidal detachment following pseudophakic CME treatment with oral acetazolamide. So we can avoid that. And there are other studies which shows that CME can occur after aphakic penetrating keratoplasty, which suggests that only when there is transpupillary anterior vitrectomy at the time of penetrating keratoplasty, there is incidence of post-op CME. And there is another study which shows CME following glaucoma drainage device surgery. There is a study which shows comparison between glaucoma drainage device surgery versus TRAB, and the incidence in GDD is more. Recurrent CME following Boston Cape Road type 2 implantation is also seen. Thank you.
Wonderful. You completed 30 seconds before your allotted time. And you can stop sharing your screen now, Team IQ Squad. We have their mentor, Dr. Sandhya ma'am, with us. And if she may unmute herself. Yeah.
Hello, everyone. I'm
Welcome,
Dr. Sandhya. Winning or losing is a part of game. What matters is what they learned from it. So I wish them all the very best for all the future sessions. Thank you so much.
Thank you so much for joining. So let's begin with the Q&A. Dr. Lala ma'am, please.
Hello again. Thank you, Team iSquad. It was a great presentation, which also very important topic and still under question sometimes, and needs more and more to know how to treat that and struggling by the surgeons. Actually, about the treatment at the presentation, they covered all the main points, but I would like just to ask with one question that when you have the treatment with cataract surgery, you have the complicated to the PCR, and you lost the vitreous, and you're not exactly sure that you have not attraction, how you will approach to the patient for the follow-up, with the follow-up.
Ma'am, following cataract, like in the cataract surgery, during cataract surgery, there was PCR.
Yeah, and we lost the vitreous, and you're not sure that you have traction or not. You saw the patient the next day, and how you will follow up the patient during the time.
We'll do normal fundus examination of the patient, and we'll check the post-op vision of the patient.
frequently you will plan to see the patient?
Sorry, ma'am.
How frequently you will see the patient? You will plan to see the patient after this situation?
If
12
the
months.
patient has presented with post-op CME,
No, you did the patient phaco, you have the PCR, you put it your lens, IOL, you have the vision acuity, and you saw the patient the next day. How you will continue your follow-up with that patient?
ma'am, firstly we
Every
will
week, every month. How frequently you will see the patient?
we'll call the patient next week to see the situation
And then,
of the to see the fundus and
yeah, you
how the
don't.
visual acuity is responding.
Yeah, and you don't show that you have the vitreous traction. Then you see the after 1 week, and then what you will do? Leave the patient, or you will call after once or after 6 months.
We will call every 3 months because even after 1 month of the cataract surgery, patient can still present
Have to
with
keep it.
chronic till 6 months, 3 to 6 months, patient can still present with post-op CME. So we can call the patient every month or 3 monthly.
Thank you. I'm done. Thank you.
Thank you, ma'am. Before I move to the next judge, I'll request the team to please switch on their video. It's switched off. Might not have noticed it. And we'll move to the next judge. Yeah, great. Dr. Hardik, sir, please. Dr. Hardik, sir.
Yes,
No,
sir is
sir,
having some
not
audio
audible,
issue. I
sir.
think we can
Yes,
go
I
to
was
the
just thinking. Dr. Vibhuti, sir, would you like
Yeah,
to take it?
hi guys. Very nice presentation. As usual, just one single clinical question from you. Which is the one disease that the patient may have, or a one specialty, I mean, a disease put into one subspecialty of ophthalmology that you'll be particularly wary about the pseudophakic CME, even after an uneventful cataract surgery? And what are the preventive measures you're going to take for that?
So uveitis is one disease we will take into consideration because there is more inflammation, so there are more inflammatory markers. So even after an uneventful cataract surgery, patient can still present with post-op CME.
Well, that'll be because of the reactivation of uveitis. But
Yes, sir.
let's suppose it's not about any reactivation. So my point is basically I wanted to hear glaucoma patients because they're on prostaglandin analogs. So before doing the cataract surgery, you have to shift the patients to another form of anti-glaucoma drugs for at least plus and minus 2 weeks. That is 2 weeks before or 2 weeks after the cataract surgery to prevent any incidences of CME. Yes. Thank you.
Yeah. Thank you so much, sir. Dr. Nimesh, sir.
Yeah, it's wonderful presentation, ma'am. So I have just one quick question. How do you differentiate a diabetic CME from a pseudophakic CME at 1.5 month post cataract surgery?
Diabetic CME
Versus pseudophakic CME 1.5 month post cataract surgery. Patient is a diabetic. He has mild NPDR sort of picture pre-op only. Now he has developed a CME 1.5 month post cataract surgery. So how do you differentiate it is a diabetic one or it is a pseudophakic CME, because the treatment protocol will change for both the situations?
Sir, firstly, we will ask the history of diabetes mellitus, whether the patient
The patient
is
has
having.
pre-op mild NPDR, pre-cataract surgery. He has mild NPDR, no CME. Now 1.5 month post cataract surgery, patient has CME. So how do you differentiate a diabetic CME from a pseudophakic CME?
We will look for the exudates and hemorrhages in the fundus. Like if the patient on fundus examination, there are hard exudates and
Okay,
hemorrhages.
I'll help you a little. Which modality tool will help us to differentiate clear cut? Almost can help us to let us know that it's a pseudophakic versus DME.
OCT.
OCT will not help us. It will show us the same picture. See, when you mentioned FFA, you saw your own FFA picture. There was a disc leak.
Yes,
Okay,
sir.
so inflammatory CMEs like pseudophakic CMEs will show some amount of disc leak or disc staining over there in the FFA, right? So the DMEs will not show that. It is itself present in your presentation. Have a look. It's there
Yes,
in there.
metalloid appearance will be there.
Yeah. So the disc is the clinical. It is a very clear cut marker for us to understand that it is a pseudophakic CME and not a diabetic CME. Right? Okay. Thank you.
Thank you so much, sir. Dr. Hardik, can you please try to unmute yourself this time?
And
Yes, sir.
am I audible
Yes,
now?
yes.
I hope so.
Yes.
Okay, so Team IQ, it was another one very good presentation. Have you mentioned about the dosing of like the posterior subclavian or the intravitreal in your presentation?
No, sir. I'm not
So
mentioned.
can you please tell me that the dosing of, because you have rightly mentioned about the use of posterior subclavian and the intravitreal. So like what is the dosing? It is right that we should recommend that, but what is the dosing of it?
0.1.
No problem. You may find it out. Find this out later. Then. So, no problem. It was a decent presentation. No problem. All the best.
Thank you, sir. So you have homework for you, Team IQ Squad. Sunday homework. Let's move to the next team. That's iSpice. I must say these are really interesting names. Please share your screen, Team iSpice.
Yes, ma'am.
And let me know when you're ready. I'll start the timer. And your time.
Ma'am, can you see, ma'am?
Yes, I can. And your time for 5 minutes starts now.
Good afternoon, all. Myself, Dr. Kartika from Team iSpice. So let's start with the story of Maya, young, dynamic teacher and a mother who is busy being it all. But in between all these, she forgot to take care of herself. She forgot to take her hypertension medications. And 25 years later, one day, when she was reading a children's book to her grandkids, she noticed that she couldn't see clearly. On visiting the doctor, she was diagnosed with retinal vein occlusion. So now let us classify retinal vein occlusion. It is classified as central, hemiretinal, branch retinal vein occlusion. And it is further divided as ischemic, non-ischemic under CRVO and HRVO, and as major, macular, and peripheral under BRVO. So the pathophysiology behind retinal vein occlusion is basically Virchow's triad. In Virchow's triad, we see endothelial injury, hypercoagulability, and abnormal blood flow. So it is seen at the retinal AV crossings where they share a common sheath at the lamina cribrosa. So the risk factors are based on the vessel wall changes due to systemic hypertension, dyslipidemia, and diabetic mellitus, and so on. Inside the vessel wall, due to blood dyscrasias like thrombophilia, and outside the vessel wall, due to glaucoma. So all these changes causes narrowing and tortuosity of the vessels and increased blood viscosity and impaired venous flow at the lamina cribrosa. So, like we have said before, CRVO is divided into ischemic, which is non-perfused, and non-ischemic, which is perfused. The symptoms are sudden painless loss of vision, metamorphopsia, and central scotoma. The signs include tomato splash appearance of the fundus and optociliary shuts. So these are the differences between ischemic versus non-ischemic CRVO. Here we can see that the visual acuity and RAPD and vision defects are more in ischemic rather than non-ischemic CRVO. And the fundus findings, there will be extensive hemorrhages compared to non-ischemic, and FFA shows capillary non-perfusion of more than 10 disc diameter and ERG reduced B wave amplitude, and prognosis is poor in ischemic. So let us see what is incipient CRVO. It is an impending CRVO and the patient presents with no or mild vision loss, and fundus examination shows dilated and tortuous vessels. In CVOA study, according to it, 34% of non-ischemic CRVO converts to ischemic CRVO in 3 years. And also, the presenting visual acuity is an important predictor for the final visual outcome. And any 2 clock hours of NVI or NVA is termed as significant, and perfusion status is based on FFA. Coming to HRVO, a variant of CRVO, including the superior or the inferior half of the retina, and it could be ischemic or non-ischemic. The symptoms are same as CRVO. So coming to VRVO, it includes major, macular, peripheral, and the symptoms are similar to CRVO. And the fundus examination, it shows a wedge-shaped pattern of hemorrhage, cotton wool spot, dilated and tortuous vessels in case of acute BRVO, and in chronic BRVO, hemorrhages are resolved, sclerosed vessels can be seen, and along with macular edema. So according to BVOA study, 40% with more than 5 disc diameter of capillary non-perfusion area are at risk of developing NVE, and 60% of these patients ends up with vitreous hemorrhage. The complications are vitreous hemorrhage, chronic macular edema, which is the most common cause of persistent low vision in BRVO, and 100-day glaucoma, which developed 3 months after CRVO. For investigation, FFA showing delayed venous filling, blocked fluorescence, neovascularization, and macular edema. No-CT is used to diagnose and monitor macular edema. FAF showing patchy ischemic retinal widening and periventricular fern-like pattern. The systemic workup should be done, and the treatment is based on the complication and severity of the condition using intravitreal anti-VEGF, steroids, or lasers. So these are the some of the landmark trials used in retinal vein occlusion. So you remember our teacher Maya, she went in for an IVR, and 2 months later, she could read books to her grandchildren. Thank you.
Thank you, Team iSpice. I'm glad you treated Maya, the patient. The teachers of tomorrow are so graphic. Thank you. And we have your mentor, Dr. P. Vijayan, sir, with us. It was an amazing presentation. Please go ahead, sir.
Yes, madam.
We would like to take your comments as a mentor for Team iSpice.
Yes, madam. I'm Dr. P. Vijay, Associate Professor. I'm happy to see that 3 of my best students, Dr. Karthika, Dr. Asla, and Dr. Sridhu, I have got an occasion for this great venue. Okay. Then they are very enthusiastic, and every other day they will ask some new questions and bringing a new topic for discussion. I often felt that ophthalmology is not a learning subject for them; it's a passion for them. So my best wishes are not only for my team, for all the teams. My best wishes for today.
Thank you so much, sir. So let's quickly begin your grilling. Yes, Dr. Shritu. Or, yeah, so Dr. Vibhuti, sir, please go ahead.
Yeah, hi. So 2 quick questions. First, and this is one of our Viva questions during my residency, so I'm going to repeat that. What is one non-dilated examination on slit lamp that you're going to do for a patient who is suspected of a CRVO?
So we can check for the neovascularization.
Where?
In the iris, neovascularization of iris. In
And
case of
that's a routine slit lamp examination. What one extra thing you're going to do?
Gonioscopic examination to look for the angles, neovascularization of angle, 100-day glaucoma in case of CRVO.
Yeah, so my next question is, in what percentage of cases you may have NVA without NVI? Can you have NVA without NVI, or does it always have to be NVI followed by NVA?
NVA can occur without an NVI. Almost
What percent cases?
10 to 15% cases.
Good job. That's the best guesswork. Whenever in doubt, 10%. Yeah.
Thank you,
First
sir.
is that. Secondly, yes, that's a correct answer. Secondly, so basically, even if you don't have an NVI, do look for NVA with gonioscopy because you'll have 10% chances of having NVA without having NVI. That's your ICO question too. It came in our clinical examination part, so that there you go, one clinical nugget for you. Secondly, your presentation revolved around the CVOS and BVOS study. And you mentioned about all the percentages. You missed out on one crucial percentage, and that will be your second question. What is an indeterminate CRVO according to CVOS study, and what percentage of it converts into ischemic?
34% of non-ischemic CRVO gets converted to ischemic CRVO according to CVOS study.
Indeterminate. What is an indeterminate CRVO, and how many percent of those get converted into ischemic CRVO?
The indeterminate CRVO.
So one is perfused, one is not perfused, ischemic or non-ischemic. What is the between one?
Ischemic is not perfused, and non-ischemic is perfused.
Yeah, and what is the middle one? So more than 10 disc diameters of ischemia is ischemic, less than 5 is non-ischemic. Between 5 to 10 is indeterminate, and 83% of those get converted into ischemic CRVO. Remember this? It's another MCQ. This was in FRCS exam. That can come in any of your exams that you may appear for. That's it.
Thank you.
Next judge, please.
Thank you so much, sir. Let's call upon Dr. Nimesh, sir, next. Over to you.
So a very good presentation, and it is very difficult to wind up vein occlusion in just 5 minutes, but you have done it. So I'll just ask a very quick question. You know the treatment of BRVO, CRVO is everything, but how do you treat an impending CRVO?
Systemic factors can be controlled. Treating of the systemic factors that is leading to the cause of CRVO. Control the intraocular pressure. Follow up the patient, and
Following up is not treatment. Treatment proper. So control of intraocular pressure could be one. Second,
can we give try antiplatelets?
okay, antiplatelets still fine. Then
So hypertension, diabetes, smoking should be restricted.
fine. Okay, we will not go deep into that. I have got your answers. Second is, do you find any role of PRP in non-ischemic CRVOs?
PRP
laser treatment. We treat it for ischemic CRVOs because
Yes,
to prevent NVG. But any role of PRP in a non-ischemic CRVO?
No, sir. No.
Okay. No problem. It is fine. This is okay to not. It is okay. If your thinking says that it is no role, it is okay. Understood. That's no problem. And role of steroids in vein occlusions?
Intravitreal steroids can be given as according to SCORE trial. We can give triamcinolone can be given in 1 milligram versus 4 milligram triamcinolone acetate can be given as a SCORE trial.
But if in case the patient is glaucomatous and glaucoma is the cause for the CRVO, then
it is a complication that intravitreal steroids can induce glaucoma and cataract.
Cataract, forget about it. Glaucoma is the risk factor. Then, and anti-VEGF is not working.
Great. Grid laser can
Grid laser for a CRVOs, I think it doesn't work at all. The CRVO is a area with a too big non-perfused one. The grid lasers will work only for central macular, like a macular BRVOs, but not for a CRVOs sort of picture. Any role of grid lasers in today era?
Sir?
Do we still do grid lasers or not?
No, sir.
Why?
Cannot. It is not useful in CRVOs.
No, not CRVO. BRVOs, macular BRVOs. Do we still do grid lasers? And I was audible, right? Do we
Yes,
do
sir,
any
yes.
grid lasers in or macular BRVOs?
According to BRVO study, we used to do macular grid laser, macular grid laser versus the
No, but today the
macular grid.
PVOS study has changed completely upside down because of the anti-VEGFs. So, do we do it? Yes or no? That's a quick answer. That's it.
No, we don't do it now.
Okay, thank you.
We need to.
Thank you, sir. I'll move next to Dr. Lala ma'am.
Thank you for the great presentation. So engaging from the starting. About the questions my colleagues before me asked many important questions, but I have only one about the treatment with the anti-VEGF. How long you will continue your treatment when you start the anti-VEGF? When you lose the NV, you will stop, or when you will stop to treat the anti-VEGF?
So, anti-VEGFs can be given to the patient with macular edema. We can give one dose of anti-VEGF. We can follow up the patient, look for the visual acuity and OCT to look for the reduction in the macular edema. We can give anti-VEGFs repeat cycles if the macular edema is not reducing.
Will you prefer to switch when you will consider that it's non-responder, or switch the anti-VEGF or switch to the steroids?
We can switch it to another anti-VEGF and see for we can follow up the patients internally to look for the OCT, see for the reduction in the macular edema.
If you have a dry macular, how long you will follow up the patient? Will you leave patient or you will follow up? If you have a
We
dry
have
macular,
to follow up the patient even after the reduction of the macular edema also. Follow up for 6 months to 12 months interval.
Thank you.
Thank you, Dr. Kartika. And Dr. Hardik, sir.
Hello. So
Yes,
it was a
you're
very beautiful presentation.
Thank you,
So
sir.
when you start thinking about like the any kind of a presentation coming on a topic like vein occlusion and making this kind of a presentation very interesting and eye catching was really appreciable. So what did you use? Like did you use ChatGPT or something else, like, or was the Perplexity the new app coming up for
We used Canva, sir. Canva app.
okay. So as Dr. Nimish sir has rightly told about the use of steroid also, apart from the anti-VEGFs. So
Yes.
even in case of massive edemas, if the patient is not glaucomatous, you can even combine anti-VEGF with ozurdex as well. So, but you need to see that it is that the glaucoma is not an issue in that particular patient. Are you able to understand? Am I
Dr.
audible?
Hardik, yeah, the latter part of your question got fumbled a little because of internet connection issues, I suppose. Could you please repeat the question?
So as Dr. Ramesh sir has rightly told about the use of steroids also. So you can even mix the ozurdex implant with anti-VEGF in a few of cases where the massive edema is there.
I think he's suggesting or asking you the use of Ozurdex in cases where you cannot give the intravitreal steroids. So voice is cracking. So if you could type your question in the chat box.
Am I audible now?
Yes.
Because like I don't
This
know
is-
like what is the issue with the network these days.
This is perfect now. Yeah, your voice is perfect.
Okay. So as I was just trying to explain you that as the Dr. Nimish sir has just told you about the uses of the steroids, right?
Yes, sir.
So even you can mix any kind of the Ozurdex implant with any anti-VEGF also in cases of massive macular edema,
Okay, sir.
right? And unless the patient is not a glaucoma patient, remember that.
Okay, sir.
Fine. Otherwise, it was a beautiful presentation. All the very best.
Thank you, sir.
Thank you so much, sir. This is for the judges to note that the fifth team could not join us, and we'll go ahead with team number 6. So on your mark sheets, could you please mention that I got this team is not here. So Iconic Tanners is the next team who will be presenting the last presentation.
This is the team number 6, sir. So judges, please mark on the team number 6.
You can share your screen, please. Iconic Tanners.
Yes, ma'am.
Last team number 6.
Just a minute, ma'am.
Yeah.
I'll start the presentation.
Yes, okay. And your time starts now.
Good afternoon, everyone. I am presenting a seminar on full thickness macular hole on behalf of the Iconic Tanners. We'll first start with the definition. It is a vitreoretinal interface disease. It is a full thickness defect in the neurosensory retina, and it involves the center of the macula. We'll go to the pathogenesis. Pathogenesis has two aspects. That is the anterior-posterior traction and the tangential traction. In the anterior-posterior traction, there is vitreous shrinkage causing a force exerting anteriorly, causing an anterior displacement of retina. On the other hand, tangential traction, because of the interaction of ILM and the vitreous cortex, there is outward pull of the retina, causing an outward force. We'll go to the etiology. The most common etiology is a primary etiology or idiopathic with no underlying ocular disease. Patient is old age with contributing factors being involutional thinning of fovea and vitreous shrinkage. Few secondary causes of macular hole are epiretinal membrane, diabetic retinopathy and retinal vascular occlusions, traumatic macular hole, high myopia, post-operative or post-procedure. We'll go to the clinical presentation. Most likely, females more common, elderly female, gradual loss of vision with a central scotoma. On fundus examination, we'll see a well-defined central red spot. We'll perform a Watsky-Allen test in which on shining a narrow slit of light, patient will experience a break in the center of the slit. Based on this, the differential diagnosis we get are full thickness macular hole, lamellar macular hole, epiretinal membrane with pseudo hole, and vitreomacular traction syndrome. We can differentiate using an OCT. We'll go to the investigations and management. Most important investigation is OCT. On OCT, we will see a defect in all layers of neurosensory retina. We'll see the base hole diameter, the hole height, the left arm and right arm length, and the minimum linear diameter. Based on the minimum linear diameter, we'll call it small, less than 250 micron, 250 to 400 being medium, and more than 400 being large. This is the IVTS classification. So in this, the first one is vitreomacular adhesion, in which there is attachment of the vitreous to the fovea, but there's no distortion of the architecture of the retina at the fovea. Vitreomacular traction is, there is a distortion of the fovea, and the full thickness macular hole, in which there is a full thickness defect with or without a partial posterior vitreous defect displacement. Gas classification is slightly older classification. Stage 1 being an impending hole. Again, there's can be 1A or 1B. Then stage 2 is stage 2 and 3 are a full thickness defect. Stage 2 being less than 400 and stage 3 being more than 400 micron. And stage 4 is again a full thickness defect with a more than 400 micron with a complete PVD. We'll go to the treatment. Smaller hole less than 250 micron. Maybe we can observe for some time. Intervention, we can intervene if for persistent symptoms or significant visual decline. There's something called ochriplasmin, in which is an intravitreal injection causes vitreolysis, 0.125 mg. Larger holes, we'll go for pars plana vitrectomy with the internal limiting membrane peeling. This is the video. First, we'll do port creation, then core vitrectomy. After core vitrectomy, we'll stain with tricot. We'll induce a PVD, and then we'll stain with brilliant blue G. We'll go ahead with internal limiting membrane peeling, in which we peel the internal limiting membrane by something called a pinch and peel technique. We do this for 2.5 disc diameters around the hole. After this, we go for a fluid air exchange. The fluid air exchange can be C3F8 or SF6. So this, and we ask the patient for prone positioning of a head so that the fluid will push the retina to join. A few precautions to be taken is to avoid air travel in high altitudes for 6 to 8 weeks. Then post-op, we can have two types of closure. Type 1 closure with good prognosis, which is without any foveal neurosensory defect, and type 2 closure is with a foveal neurosensory defect, which has poorer prognosis. Few recent advances, there's something called an internal limiting flap technique, inverted internal limiting flap technique, in which instead of complete removal, we'll keep a pedunculated flap over the hole, as you can see in the video. With taking a flap and depositing over the macular hole, which gives a scaffold for tissue proliferation. Few types are 360-degree ILM flap and a temporal ILM flap. Finally, there are the grafts, the amniotic membrane graft, or we can use autologous retinal graft. Thank you.
Thank you, Team Iconic Tanners. Well within time. And I would like to welcome your mentor, Dr. Debulina Dev.
Yeah, hi, this is Dr. Devalina.
Hello.
So, so this is a very good platform, I feel, for all the residents to really present. And also, it's very academically interactive. They're preparing them for the Vivas. It's a very great initiative by Yosi and amongst all the other initiations. So yeah, all the presentations I saw from the other residents also fabulous. And I feel the trend of presenting is also changing. And everyone is gathering new insights into how to present also, which also will help to present in the different podiums and different platforms in the conferences. So it's a great effort. And kudos to all of them and to Yosi definitely for bringing this up. And yeah, you can take it forward for the questions now.
Thank you so much. Rightly said, there is so much to learn from these students. I see it myself in my personal opinion. So let's begin. The last team, that's Team Iconic Tanners, team number 6. So judges, Dr. Lala ma'am, would you like to go first?
Thank you. The presentation is so great, engaging, well understandable, and thanks for your contribution with this great presentation. You worked on that so hard, it seems. About the questions, I would like to ask that are you using only the flap techniques? Here you mentioned about the grafts. Are you using in the practice the other techniques like the tenons or the anterior capsule or other techniques for the closing the macular holes, or are you using only ILM and inverted ILM flap techniques?
You're asking in our hospital?
Yeah.
In our hospital, we either do internal limiting membrane peeling or flaps only. Other than that, those are the only two techniques that we use.
Okay.
Inverted flap or for chronic cases, we can use amniotic membrane grafts or a retinal autologous retina graft. But in our hospital, we use inverted flaps most commonly for larger holes. Smaller holes, we do go for peeling.
Okay. And the other question is, when you prefer, when you see the patients, how you explain the patients about the outcomes, and when you prefer to take the patient, the case, when you prefer to take the patients to the surgery, which size of the macula?
Ma'am, less than 250 micron, we can wait for spontaneous closure. We can follow up the patient for lamellar holes as well as for less than 250 micron holes. Maybe we can wait for 1 month. I've read somewhere it is from 30 to 50% times they do close spontaneously, so we don't need to operate. If the symptoms persist, then we can take up for PPV and ILM peeling. For larger holes, we definitely have to take up for surgery. Larger the hole, the poorer the prognosis, the minimum seeing by minimum linear diameter. Also, other aspects which give poorer prognosis would be a chronic hole, which has not been seen for quite some time, will have poorer prognosis. And pre-op best corrected visual acuity is also a predictor of outcome. So we also see that. We also have a very guarded visual prognosis in macular holes.
Thank you. That's all. Thank you so much. Good luck.
Thank you, ma'am. Over to Dr. Vibhuti, sir, for his questions.
Yeah, again, two questions for you. First, what is a heavy BBG dye?
Yes, sir.
What is a heavy BBG dye?
Heavy BBG dye. I'm not really sure.
Yeah, so the video that you showed when you put in the dye and the dye disperses, right? So the dispersion causes inadequate staining at times. So sometimes you can, I mean, there's a type of BBG dye which comes pegylated. That is, it comes with a combination combined with a polyethylene glycol. That's a
Yes.
heavy dye. It stays on the ILM and stains it more uniformly.
Yes,
So that
sir.
is one. Second, I don't know if you have heard about this, but not only for the judges Q&A, but also for an information. Do you know something about the shift flap technique of macular hole surgery?
I'm not really. I know few flap surgeries, but I'm not really sure of the shift flap surgery.
Yeah. So shift is it's one of the most latest described techniques where it's basically the full form is superiorly hinged inferior flap technique, SHIFT. So what you do is you lift the inferior flap, go across the hole, and you leave it superiorly hinged. So with gravity, and then after you do the fluid air exchange, you leave it as flat. So you don't need to have post-operative positioning, the uncomfortable post-operative positioning by gravity itself. The flaps stay in its place. So this is the latest that has been described. The utility and the effectivity of it still needs to be seen.
Yes, sir.
Thank you.
Thank you, sir.
Thank you so much, sir. Dr. Hardik, sir.
Good presentation again, team. So just wanted to know, as you mentioned about the use of C3 gas and the SF6 as well. So
yes, sir.
what will you do if you have a overseas patient or a patient who's like who has a planned air travel?
Yes. So in patients that
So you cannot make them stay for 6 to 8 weeks at your place, right? So
yes,
what
sir.
will you do then?
So in patients who cannot do head positioning or have to have air travel or high altitudes, we can go for silicone oil tamponade instead of a gas tamponade. That can be useful in
Very
keeping. Yes.
Yes, very nice. Because what really matters is the prone positioning over here.
Yes.
So in case if anybody has traveled, if
We lost you in the end.
all the best.
Thanks.
Yeah, thank you, Dr. Hardik, sir. Over to you, Dr. Nimesh, sir. Quick questions for iconic tanners.
So I just have a quick question. Instead of C3F8 SF6, can you use only air as a tamponade for a macular hole surgery or not?
We can use, not used routinely, as far as I know.
Can be used. Sure.
I had read it somewhere that C2F6 and pre-air also can be used, but I'm not sure if it's used regularly, routinely.
Okay, so that was the answer to your previous scenarios where you can use only air as a tamponade and it will still work.
Yes,
it is only
sir.
3 to 4, 5 days initially where you require the hole to stay closed.
Yes,
Post
sir.
that, gas doesn't have any role.
Yes,
So the
sir.
closure happens in 24 to 48 hours. You take a good scan, you still see a hole closure.
Yes, sir.
So you mentioned about the classification of macular holes. So do you know something about stage 0 macular hole?
Stage 0 macular. So in stage 0 macular hole in gas classification is just equivalent to vitreomacular adhesion of IVTS, in which there is attachment of the vitreous to the fovea.
So why there is stage 0 when there is no attachment, when there is no macular hole? Why stage 0 or still mentioned as a stage 0? Any relevance or importance of that?
Maybe the patients require follow-up if they're progressive in
The risk
stage.
is higher than the normal population where a mitromacular adhesion is there. That is stage 0.
Yes,
Third
sir.
and the last quick question is you mentioned about the size of ILM peeling.
Yes, sir.
So does it matter? So there's a study which says does the size really matters? So that is my last question to you. You mentioned 2.5 millimeter removal of ILM.
2.5 disc diopter is what I had
2.5
read.
feet diameter is almost 5 millimeters. So 5 millimeters is a huge area to remove the ILM. How far is fovea from the disc?
2
Can
disc
you remove?
diopter.
How will you remove 2.5? Not possible. So it is in MMs, not in disc diopters. So I think the units was wrong. It is 2.5 millimeter. So it does the real size really matters if I remove only one millimeter?
It does matter. We have to remove.
No, it doesn't. So it's okay. So this is just to know for you to know. Size doesn't matter. It's minimal removal of ILM around the hole, so the edges are free, and
Yes, sir.
the traction over the hole flaps have been relieved, so that the hole can go and settle down on its own. So the tamponade just helps us, but air, gas, anything. Air is little, its density is little less. Those gases have a density little more, so they will work better. But if in case the air travel is there, and you don't want to put an oil where the second surgery has been required, air can work in such situation for smaller macular holes, not for big macular holes.
Yes, sir.
Small macular holes, it will definitely work.
Yes, sir.
Thank you and a wonderful presentation.
Thank you, sir.
Thank you so much, sir. Thank you, Team Iconic Tanners. And with that, we finish the first round. I would like to call Dr. Sahil here to moderate round 2. And while he shares his screen, let me tell you that the 5th team is not with us. So keep in mind, judges, that the marking for team 5 is to be omitted. The second round is much more terrific than the first round because all work and no play makes Jack a dull boy. So we can move to a creative round. And Dr. Sahil, the first team is triple IQ. If I'll try it on my behalf once. Dr. Sahil, are you there?
Hello. Hello.
Yes, sir, you're audible.
Okay.
Should I stop sharing the screen?
No, you can continue, no issues, ma'am. Anna.
Okay,
So just yeah. Thank. Okay, so we have now shifted to round 2 after a very exhaustive round 1, I suppose. I think out of the last year's residents, this round 1, last year's round 1, this is one of the very extensive and exhaustive round 1 which has been covered. And I really thank all the judges for actively asking so many questions. And I'm pretty sure that residents would have realized that they have a lot to go about. So now this round 2 is very simple. Not many question and answers, where each team one video will be played and the judges will mark it accordingly. And at the end of each video, we will have a small comment from one of the judges. So let's play the videos. Rituji, are we playing videos from outside only? So shall I
Yes,
play
yes.
the videos?
Yes,
Okay.
yes.
Okay. So so we'll start with the first team. The team name is, or maybe you can stop
Yeah,
sharing.
I'll
I'll
stop
continue
sharing.
with this
Yes,
thing. Yeah,
it's Triple
yeah.
IQ is the first team.
Okay.
And let's pitch
Just
in
a
some entertainment to this
Yeah. So
academic
let's start
event.
the screen sharing. So round 2 and 20 marks, and then this is the triple IQ first video reel. I'll be starting. That's that. So that is about the triple IQ team video, and just a second, I'll stop sharing. So I would like to invite Dr. Bibhuti sir for a quick comment on this particular creative video.
I think the video was great. Serves across a great message, and that ROP is preventable if treated in time. But there is a way. This disease doesn't have a gray zone. It is a purely black and white disease. Either the baby sees completely, or the baby goes permanently blind. So well done, team Triple IQ.
Thank you, sir. In the benefit of the team time, for the benefit of the time, I will now move to the second video. So the next team is Vision Ledger. Their creative round.
मम्मी क्या कर रहे हो? क्या हुआ? शाम होते तो कुछ दिखता ही नहीं है मुझे. आपको क्या हुआ? क्या कर रही हो? इस फोन में कुछ दिख नहीं रहा. अरे इतना तेज ब्राइटनेस बंद करो. नया फोन ले लो तुम. अरे बेटा फोन अपडेट नहीं है, आंखें अपडेट मांग रही हैं. अरे मम्मी आपको भी तो शाम में कम दिखता है ना. ये तो अपने घर की परंपरा ही है. परंपरा या दिक्कत? मैडम जी आइए. आप दोनों से मरीज कौन है? हम दोनों ही मरीज हैं. बताइए क्या तकलीफ है? शाम के समय में हमें दिखना बिल्कुल कम हो जाता है. दिन में तो ठीक दिखता है. ऐसा कब से हो रहा है? कब से? काफी समय से. रात को तो हम सब पावर सेविंग मोड पे चले जाते हैं. कभी कभी ये मजाक नहीं होता. आप दोनों की कुछ जांचें कर लेते हैं, गाड़ी रखिए यहाँ पे। अरे मम्मी, अरे ठीक, आप दोनों को तो रतौना यानी रेटिनाइटिस पिगमेंटोसा हो सकता है। इसमें सबसे पहले रात में दिखना कम होता है और उसके बाद धीरे धीरे साइड से दिखना भी कम हो जाता है। ये क्या होता है? ये एक जेनेटिक बीमारी है, पीढ़ी में तो चली आती है। इसका क्या इलाज है? ये ठीक तो हो जाएगा ना? देखिए अभी इसका इलाज संभव नहीं है। अरे हमारा तो पूरा लाइफ ही खराब हो गया। अरे आप शांत हो जाइए। देखिए इसमें कंट्रोल करना और समझना बहुत ही जरूरी है, इसलिए मैं आपको जेनेटिक काउंसलर से मिलवाना चाहती हूँ।
One eternity later.
ये क्या नई बीमारी है? इन दोनों को ही रेटिनाइटिस पिगमेंटोसा हो सकता है। अरे इसमें तो जेनेटिक काउंसलिंग सबसे ज्यादा जरूरी है। काउंसलिंग? दवाई गोली से कुछ नहीं होगा क्या? दवाई से ज्यादा इसमें जानकारी की जरूरत है। हम आपको बताते हैं कि ये क्यों होता है, इसमें क्या होता है और आगे की पीढ़ियों को कैसे बचाया जा सकता है। अगर जानकारी से आगे की पीढ़ियां बच सकती हैं, तो हमें सारी जानकारी चाहिए। बिल्कुल, आज जानेंगे तभी आगे बचा पाएंगे।
जेनेटिस पिगमेंटोसा एक जेनेटिक यानी अनुवांशिक बीमारी है, यानी यह परिवार में आगे बढ़ सकती है। इसके मुख्य इनहेरिटेंस पैटर्न है ऑटोसोमल डोमिनेंट, माता या पिता में से किसी एक से भी आ सकता है। हर बच्चे में 50% जोखिम रहता है। ऑटोसोमल रिसेसिव, दोनों पेरेंट कैरियर हो तो बच्चे में बीमारी हो सकती है। एक्स लिंक, आमतौर पर मेल ज्यादा प्रभावित, फीमेल कैरियर हो सकती है। जेनेटिक काउंसलिंग से पता चलता है कि उसके परिवार में कौन रिस्क पर है और फ्यूचर प्लानिंग और अर्ली डायग्नोसिस संभव होता है।
यह सिर्फ आंखों की बीमारी नहीं है, जीन्स की कहानी है। समझिए, जांच कराइए और अगली पीढ़ी को सुरक्षित रखिए।
A very nice combination of subtitles in English and the audio in Hindi. I would like to invite Dr. Nimesh sir for a quick comment on the creative role of this team.
So you have it's a very wonderful video. You have got out a very important aspect of retinitis pigmentosa. We have always been counseling patients about there is no treatment, but yes, genetic counseling is very much important in this situation, because it is the gene study which will let us help, which will help patient later in life if in case any treatment is coming up, and how can we arrest the progression of the disease in the near coming generations. So definitely this aspect has been missing, and you have pointed out really very well. A wonderful reel. Thank you.
Thank you, sir, for the motivational comments on the creative round. Moving up to the third team. This is the team IQ squad.
Everything looks so clear, so perfect. I love this. I wouldn't be so confident. Sugar levels are kind of high. Come on, I feel absolutely fine. I can see clearly. That's all that matters. I'm struggling to handle this sugar.
دوس عندي خوش فاصلة يا أخي تفوز والله خوش رقصة يا أخي دوس عندي خوش فاصلة يا أخي تفوز والله خوش رقصة يا أخي دوس عندي خوش فاصلة يا أخي تفوز والله خوش رقصة يا أخي دوس.
Did someone say sugar? I'm just gonna hang around a bit.
That's fine. I feel normal. Anyway.
See, nothing is wrong.
You don't see it now, but the damage has already started.
A few moments later.
Wait, what are these tiny spots? Maybe I'm just tired. See, that's what I was trying to warn you about.
Oh, Dad, just affecting your tiny blood vessels. Nothing you will notice early.
This is what uncontrolled diabetes does. Why is everything getting blurry? I can't see properly.
I don't make noise. I destroy silently.
No, this can't be happening. Control your sugar levels and get regular eye checkups.
Wait, so if they control me, I will lose my power?
Exactly.
By the time you notice vision loss, the damage has already occurred. Sugar is sweet until it blinds you.
So another very creative thing. I would like to invite Dr. Lala ma'am comment on this particular video part.
Thank you. Thank you. The video is so creative and so well understandable. Thanks for that. And so it's a great message. So important and a great message overall like that. to how you explained the situation. It's mostly, unfortunately, in Azerbaijan, we had a great problems to explain to the patients the situation, to come up the follow-up, to come up the eye exams. Congratulations, girls. You did a great job.
Thank you very much, ma'am, for the sweet comments on the sugary disease. I hope we are all controlling everything in that aspect. Let's move on to the next team. So the next team is iSpice and their creative video reel.
उठ जा अपनी राख से दूर जा अब तलाश में परवाने की आत्मा भी सर उठाएगा आएगा अपना टाइम आएगा.
Some people chase dreams, some people survive through them.
प्रेशर कुकर जैसे सर की बच जाए ना सीटी तब तक मार रट्टा मार.
Hello. Hey, how's it going?
Can I call you later? I'm a bit busy now.
But this is what you said last time. Are you even taking any breaks?
No breaks this time.
My son will get it this time. Day of the exam. No holding back. He's ready to give his best shot today. All of a sudden, he couldn't see clearly. This can't happen today. Rahul?
Come on, you can do this.
Everyone in the exam hall was busy writing, except him. Hey, the paper was easy this time, right? After the exam, he straight went to the doctor. Have you been having any stress lately? He knew the answer to that.
I think this is central serous retinopathy, which is more common in young males. So we'll take a scan for the confirmation. As you can see, this is a fluid built up beneath the retina. So this is more common in type A personality, stress, sleep deprivation and anxiety. So you have to prioritize your health. So take frequent breaks in between your preparation. Take good rest this time and all the best for the next preparation. We'll see you on next review.
When the results came out, he already knew deep down he had failed. That didn't stop him. He rebuilt his approach with discipline, breaks, and better self-care. Stress doesn't just break you, sometimes it could blind you. Protect your peace, protect your vision.
I hope everything is going from academics to a little bit more entertainment. And so now I would like to invite Dr. Hardik sir for comments on this particular video reel, sir.
Right now, actually, I got my flight at 6, so maybe I will be little like on a silent mode. But it was a very good presentation, and I'm really impressed by this team. Looking at their PowerPoint presentation, which actually they made from Canvas, as she said, and again the CSR thing. It is really appreciable, and just with the running course of day, with the running the lifestyle, the CSR is among the most prevalent. It is going to be the most prevalent disease, even more than DM some days. I feel. It was a good presentation, guys.
Thank you, sir. Thank you, sir, for the quick. Moving down to the last team. So the iGlotis team are not there. So this is the reel of the team number 6 for the judges so that they can mark it appropriately in the mark sheet. Iconic Tenors is a team name. This is the reel.
A 30-year-old woman started a normal day by doing her routine activity. But as she was running, she noticed some light flashes, a few black dots in her vision. She ignored these signs and went to sleep. Decided to go for a nice run by the lakeside in the morning. But as she woke up, she saw some black shadow in her vision. She got scared and went to the doctor for checkup. She told the doctor that she's seen some black dots like flies in her vision since one day. Said that her left eye is affected. and was sudden in onset. As she showed her glasses to the doctor, she mentioned that she is a high myope of -10. The doctor started examining the patient. As the doctor finished the examination, he told to the patient that she has a problem in her retina. The problem was a retinal tear, which had turned into retinal detachment for her. It was not just a diagnosis, but a loss of vision. The doctor mentioned as the retina separates, we see floaters and flashes. And a severe sign can occur like a curtain falling in front of the eye. Never to ignore these signs of retinal detachment. Yearly screening in high myopes is a must, because vision once lost might never come back.
So this was the last team reel. I would like to invite again Dr. Bibhuti sir for the quick comments on this particular reel.
Yeah, a very well and a very creative video. Nice graphics used and conveys the message very, very clearly in the given span of time. I don't think there is any more to add given the time constraints.
Thank you. Now I would like to shift. I would like to ask Dr. Uma ma'am to take over the presentation.
Thank you, Sahil. And I would like to thank our esteemed judges, Dr. Lala ma'am, Dr. Bibhuti sir, Dr. Hardik sir, and Dr. Nimesh sir. We are truly honored and privileged to have you here with us. Thank you so much. It was such a great learning experience. And I'll be sharing your e-certificate here. We'd love to have you for the next 2 rounds, but we can understand that because of the time constraint and your other commitment. So we'll be very happy to have you. And we'll have a quick photo session also. So all of you, please, yeah.
I will stop. Please switch on all of you can please switch on your video so that you are requesting mentors also if they are present over here to please switch on the videos, ma'am, and the judges so that we can have a quick photo. Numerotech people need to let us know when.
Iconic Tanners, Team IQ.
Yeah, a quick.
Switch on your video quickly because the judges are waiting.
Yeah.
Let us know when they are ready. Like,
yeah.
Okay, so have they taken up the screenshot?
Let's do one with the Yosi sign as well.
Okay. So we can have the sign of the Yosi over
Everyone, YO.
Please requesting.
1, 2, 3.
Yeah.
Thank you. Thank you so much.
Thank you.
One of our judges even tried to mouth the answer during the Q&A session. The candidates are really lucky to have such judges. Thank you again. Yes, Dr. Roma, please.
So we'll move on to next round, round 3, which is our knowledge nexus. So it will not only test your knowledge, but also your reflexes, finger reflexes. So it is fastest finger first round. So each team will, this round will have 10 questions and it will have all the multi-specialty. All the teams will be given 20 seconds to answer. And you have to remember your team number and you have to type your team number in the chat box. Okay. And correct answer will give you +1. But if you are not able to answer or if you give wrong answer, you will get -2. So there are 3 audience questions also. So audience, please be ready. And you can win exciting prizes. So this is our trial question. We'll start. All of you ready? Get set.
Dr. Ritu, will you maintain the chat box?
I am doing that. Yeah. Team 2 has first typed their number. It's Team Vision Ledgers.
I think they can type only once the question has been read. So once let the question be read and then please type.
Hyderabad.
Okay.
I have typed 4 X's, and after this, nobody can type their team number till Dr. Roma finishes the question. Yes, please.
Okay. So we'll move on with the actual quiz now. Shall we start? Dr. Sahil, can you move the
Okay,
slide?
just hold on. Yeah. So everything is ready, chat box and everything. I'll
Yes,
go ahead
yes,
with the
yes.
question.
So the first question is, which form of rhabdomyosarcoma has the worst prognosis? Which is the first team to
Actually,
answer?
before you finished the question, Team Vision Ledgers had typed. So we'll move with the next team. That's Team IQ Squad. Third team. Dr. Sakshi Raj can unmute herself and give the answer.
You have only 20 seconds to unmute and
Ma'am,
answer.
answer A, Botroid.
Which team is this?
Sir, Team IQ Squad.
Team number?
Three.
Team
Yes,
number
yes,
3, sir.
yes, yes.
Three, na? Okay, okay, wait. Just now I'll go down to the answers.
So the correct answer is C, alveolar. So this was the wrong answer and you'll get
-2.
-2.
Team 3 -2. Okay.
So
Noted.
next question. Which of the following is the most common cause of pupillary sparing third nerve palsy in adult? A, trauma, B, aneurysm of PCA, C, microvascular ischemia, or D, tumor? Dr. Ritu, which is the
Yes.
first team to
It's
answer?
Team iSpice, team number 4. They can unmute themselves.
Microvascular ischemia.
So that's the correct answer. You got +1 for that. Please note. Third question. Oh, this is the audience question. Please be ready, audience. Which of the following structure exit the cranium through the foramen ovale? A, mandibular nerve, B, main meningeal artery, C, greater petrosal nerve, and D, oculomotor nerve. So this is an audience question. Audience can answer, not from the team. Anyone, Dr. Ritu, from audience?
Yes, I have Dr. Shazia. Please unmute yourself.
Option A, mandibular nerve.
So yes, that's the right answer, and you'll get an exciting prize. We'll let you know the details shortly.
So Shazia, please drop your contact number in the chat box once. No?
Okay, sir.
So next is, which of the below is most commonly lost muscle in squint surgery? A, medial rectus, B, superior rectus, C, lateral rectus, and D, superior oblique.
It's Team Vision Ledgers, second team.
A, medial rectus.
Yes, that's the right answer, and you got +1 for that.
This was team 2, right?
Which of the following is the most common complication associated with Fuchs heterochromic iridocyclitis? A, cataract, B, glaucoma, C, retinal detachment, and D, optic neuropathy.
So 2 teams typed up their team numbers before you could finish the question. It's Team iSpice, team number 4.
Glaucoma.
That was the wrong answer, so you got -2 for that. The correct answer is cataract. Most common is cataract. Next question. According to EVS, which patient with acute post-op endophthalmitis should undergo immediate pars plana vitrectomy? A, patient with hypopion, B, patient with visual acuity of hand movement or worse, C, patient with corneal edema, and D, patient with vitreosis.
Team Vision Ledgers finished up after you completed the question. So team number 2, unmute
Patient
yourself.
with visual acuity of hand movement or worse. B option.
Okay, that's the correct answer, and you got +1 for that. Next audience question. All of the following are supportive for the diagnosis of ocular toxocariasis except A, clinical presentation, B, hypersensitivity in the skin testing, C, intraocular antibodies, or serum IgG and IgM in ELISA. Anyone from the audience?
They're following all the rules. It's Dr. Shazia again. Please unmute yourself.
Is it option B?
That's the correct answer. Congratulations, Dr. Nazia again. Next is lens fiber contain nuclei in all of the following condition except A. Trisomy 13, B. Syphilis, C. Rubella, and D. Loeys syndrome.
Team Vision Ledgers, team number 2. Please unmute yourself.
D. Loeys syndrome.
That's the wrong answer. So you get -2 for that. Correct answer is syphilis. All of the following visual acuity test uses letter except A. Kay's chart, B. Sheridan-Gardiner, C. Logmar, D. Snellen's chart.
Team Triple IQ, please unmute yourself.
The answer is A, case.
Okay, so that's the correct answer. It uses pictures. And you get +1 for this.
This was team 1 triple IQ, right?
Team 1 Triple IQ, yes.
So next, which of the following drug is used to treat conjunctival papillomas? A. Rapamycin, B. Picibanil, C. Bleomycin, D. Cimetidine.
Team 2 Vision Ledgers, please unmute yourself.
D. Cimetidine.
Okay, that's the right. Yeah, that's the right answer, and you'll get +1 for it. Audience question: which of the following is the most common mutation associated with LHON? G11778A, T14484C, G34608, C12543T.
This is from Clashes, Dr. Shakira.
Okay.
Option A.
That's the correct answer, Dr. Shakira. Congratulations. Please enter your details in the chat box.
Sure, ma'am.
Ninth, identify the instrument. Is it Ritling stent, Minimonoka stent, Crawford stent, Kanika Lacriflow stent?
Fourth team, Team iSpice.
Ritling stent.
Okay.
Option A.
Yeah, that's the correct answer. You get +1 for it.
This was team 4.
Yes, team 4. iSpice.
Last question.
Last question is, all ready? What is the most likely diagnosis? Is it plateau iris? Is it pigment dispersion, IC syndrome, or Posner-Schlossman?
Team Vision Ledgers, team 2.
Pigment dispersion syndrome.
Okay, that's the right answer, and you get +1 for this.
Okay, so we
Yeah.
And
Please ask Dr. Shakira to mention her contact number as well later. She has mentioned Team
Yeah.
Flashes is her team. I guess she's
Sure,
one of the
madam. I will.
participants.
Yes, madam. I'll enter.
Yeah, okay. Thank you.
Dr. Sahil, you'll continue with round 4.
Okay. Doctor, shall I take up or Dr. Roma? Sorry, Dr. Ritu, will you be taking up?
I'm
You can take it.
comfortable, yes. Yeah.
Yes. Okay, then please go ahead.
Mm-hmm.
You
Thank
take
you.
up.
Yes.
अभी timer, madam, Dr. Roma, ma'am, you manage the timer, है ना?
Yeah, I'll check the timer.
All right. So last but not the least, let's go back to your kindergarten days where each of you will be playing one by one, and only one of you would be here from the team, representing the team. You'll have 6 jumbled words. You have gone through the trial question again. We can omit that as well. You'll have 1 mark for each correct answer, and there'll be 6 questions. So all in all, you can fetch +6 within 1 minute. Mind it, +6 within 1 minute. There is no negative marking in this round. So go ahead, shoot all your, just guesses.
In case, if there is any audio disturbance from your side, please type in the chat box your answer so that we can take it into account. Okay. This is
Shall we omit the trial round this time?
yeah. Okay.
Yes. Okay. They are well versed with it, and let's begin unjumble the words. Team number 1.
Your time starts
time.
now.
Team 1, you can unmute yourself. Triple IQ. There are no negative marking. Team Triple IQ.
Yes, we are here.
Okay.
Last 10 seconds. Time up, please. Team Triple IQ, are you ready?
Yes.
They were ready, but yeah, somehow it's all right. These were the answers to those, Wordsmith war. And we'll go ahead. Team number 2, your time starts now.
Leg ophthalmos. Last one is leg ophthalmos. First one is Botox.
Second is macula.
Second is macula.
Fifth is hypopyon.
Fourth is diplopia.
Third.
Pentacam. Third is pentacam.
Pentacam.
Third is pentacam.
I'll request
All correct.
the team members. I know you could be prompting one of you, and as I had told you in the dry run, to avoid any confusion, let only one person speak. Yes? And good. That was a +6.
Excuse me, ma'am.
Yes.
I'm so sorry, we didn't understand. We were like, you will ask us and then we'll say. So we waited for 1 minute to end. We had solved 3 of the thing. So if we can get another chance, please.
We have one set of questions that is team number 5. I got this. We can give you that. But
Yes.
this was already done twice, right? The
No,
whole
ma'am,
trying. Yes.
actually, it was written time to solve. So is 1 minute. So we were
Yes.
actually solving it. We were not saying it aloud.
No. Once it was done, we were even. Oh, it's okay. Let's just cut it short because we do
So
not have
sorry,
much
ma'am.
time.
I'm so
We'll
sorry.
get it back to you once we display team number 5. You can attempt. You'll just have 1 minute to guess all the words, just like you did it for the fruits. If any one of you wants us to go again through the trial questions, you may say so now, or we'll continue with the rounds. Are you all right with it? Team 3, you're the next team. Are you well versed with the rules?
Yes, ma'am.
Okay. Cool. All the best. So, team
Team
number 3.
Time starts now.
One is the Cryops, and then Snellen. Second one is Snellen, and third one, Volkstraya, Snellen, the Cryops, and so on. And cones. One is cones, and one is Tenon, and then is Keratoglobus. Fifth one is Keratoglobus.
The first one was not Tenons.
First, I think.
Tonopin.
Okay, so how many? 5?
+5
correct.
for them.
5 correct.
Great.
Right?
Team 4, are you ready? Buckle up.
The
Yes,
time
ma'am.
starts now.
Yes.
First one is canaliculitis. Spasm. Blepharospasm. Keraton. Then and orthophoria.
Just one member, please.
Last 10 seconds.
Yes.
And rethink your question answers. I'll only consider what you spoke through your mouth.
Orthotropia, ma'am. Like second one is
Okay,
orthotropia.
Time up. Sorry.
All right. So they fetched +4 here. Great.
4?
I couldn't get blepharospasm. Wow. You people
Yeah.
were quick.
4, I think 4, right?
Yes, +4.
Team 4 plus 4.
We have a set of questions. I will reiterate. It's for I got this team who unfortunately couldn't join us. Team 1 can attempt this set of questions. So team 1, are you ready?
Yes, ma'am.
Yes, all the best. And throw as many answers you can get. Yeah?
Okay.
Shoot.
Your time starts now.
Ma'am, one is uvea. Macular hole. Fourth one is no. Dry retinoscopy. Second is, I think, dry retinoscopy. No.
Keep trying. Skip to 4th or 5th or 6th. Anything.
Blind spot. Ma'am, fifth one is a blind spot. And
Great going.
Last 10 seconds.
If you can't get the longer ones, go with the small ones.
Time up. Thank you.
It's all right. You get a +2 here.
+2?
Yes.
+2.
So it's labeled team I got this, but it was team triple IQ.
Yeah. Team
They
1.
get +2. Yes.
Last team.
It's team 6.
Ready?
Set and go.
Go.
Start.
Team Iconic Tanners. Unmute. Yes. good.
Second. Fourth is rods. Third is eye drops. 5 is photoreceptors.
Good.
Lamina cribrosa is sixth one.
You've
First
answered 4
is
so far.
scleral plug.
Sorry,
One
the
more left
first
out.
is
Last 10 seconds.
What?
Which one
Only
Which
one
one is
left out.
left?
first
Third
and
one.
second.
Eye drops.
No, first they have answered.
Eye drops.
Yes.
Time up.
First they have
Everybody.
Time
answered.
up.
Time up. So was
Ciliary,
ciliary
eye
body,
drops,
I
rods,
think.
photoreceptor.
Yeah, ciliary body, I think they did not answer.
We
Right?
said ciliary body.
You said, na?
We answered ciliary
We lost
yes.
them in between. Yeah, even right
Yeah,
now
plus
their
6, I
voice
think.
is a little
Yeah.
glitchy.
It's 6 plus 6. I think they have answered all of them.
Yes.
Yeah.
Yes.
Okay.
Photoreceptor, lamina cribrosa, right. All 6 correct. Fine.
A +2 for team 1, a +6
For
to
the team 6.
+5, +4, and +6.
Yeah.
Great. This was amazing. I must say that we did not really thought that it would go this long, but many of you were grilled by our judges. A learning experience for us as well. Thank you, teams, and we'll go ahead with your certificates. I guess they were all fastened, and you'll receive these certificates in soft copy on your Gmail. Thank you, each one of you, and please do register for YosiCon. We can look forward, as Dr. Nupur said, it's not about the winning team attending the conference this year. Let's have all of you. And we can have a quick photo.
Comments? Any of the participants, how was it? Any few, 1 or 2 comments? Anybody volunteering? How was the session? Anything which we also need to improve or we need to take care of it? Anything, any issues which you guys faced? Yes. Anybody? Please feel free. Residents. Anyone?
Mentors can also.
Yeah.
And the judges can too. I see the judges are here with us as well.
Thank you, judges.
Bye, ma'am.
Thank you, ma'am.
Okay, so residents, I hope this went off very well. And
Yes, ma'am.
fine. So certificates will be sharing them directly on the participant group, right?
Yes.
Okay, fine. So okay, done. So let's.
We had to run a sprint. I think pura
Sorry.
ek round went till 2 hours, and within half an hour, they had full of adrenaline. All the team members, they did a great job because we had to run a sprint in the end. And you all deserve a coffee break now. Go and enjoy. By 8 p.m., you will know who the winners are. The judges have the mark sheets, and they will soon share it with us.
Yeah, all of them were really good. Keep growing, keep learning.
I must say thanks the UC for organizing such activities. Very frequently they are doing a great job, and especially for inviting us to participate in such events. It's a pleasure for all of us, and my trainees Shafaq, Mariam, and Farhan. They are very enthusiastic, eager to learn. They are very creative. Students, trainees. So I wish all the teams the very best, and to my team as well. And I must say one thing about my team, my trainees, the Shafaq and Mariam. They were among the 2% in the world who scored highest in ICO examination. So they are very brilliant. They are all the time taking active part in research and in academics. So I must say, very
That's
good
a
to them.
commendable thing.
That is commendable, and we are also fortunate, ma'am, that such residents are participating on this platform also. So it's a pleasure for us, and it's an honor for us also to have them on board. And thank you very much, ma'am, for staying for such a long time and being a very motivating mentor for them. The thing.
Yes.
So
Thank you.
we'll wind up now, and all the best, guys, and see you at Yosi. Fine.
Yes.
Bye.
Bye.
Thank you, Manjula ji.
Thank you, Manjula ji. Take care. Bye.
Thank you,
Okay.
Doctor. Thank you.
Yeah.
Bye.
Doctor, I will share the backdrop tomorrow for next Yosi
Yes.
webinar. Sorry.
Yeah, it's completely fine. We have a day, a
Yeah,
week.
I will share it tomorrow, Doctor.
Yes.
Definitely.
Thank you.
Thank you, Doctor. Thank you.